So I actually thought of behavioral and psychological symptoms in geriatric care because although the term was initially introduced for dementia, behavioral and psychological symptoms, they do occur in a large number of neurocognitive disorders, which are not necessarily dementia. That is the current understanding. Even last few years, there are a lot of attention. Any geriatrician will be seeing behavioral and psychological symptoms, even with mild cognitive impairment or without any cognitive impairment at all. The new developments are interesting, but as we all know, it mainly happens in dementias. Interestingly, in our part of the world, it is the behavioral and psychological symptoms of that actually leads to consultation mostly, because they find it difficult to keep their loved one, the elderly person, at home. And we are well aware, behavioral and psychological symptoms consider a major component of dementia syndrome, irrespective of its etiology, or the type of dementia. And as I said, it's the main problem of carers and service providers. In any ward who's giving dementia care, in my wards, this is the main problem, not the cognitive impairment, the complaints from the nurses, the carer, the family, mainly the behavioral problem. And the current understanding is 97%. That is almost all of them are having this problem. And they are also called neuropsychiatric symptoms, depending on the country that they use it now. Most of the Americans, North Americans also prefer neuropsychiatric symptoms, because the word is interchangeably used nowadays, because the fact that I told it can happen in any geriatric patient. So that mainly the word is NPS, confined to cognitive normal people nowadays, right? And it can be the first symptom in appearing some disorders like Alzheimer's and Parkinson's. This is the type of behavioral and psychological symptoms you see in geriatric care and dementia patients. You see that they occur in clusters, right? From apathy, depression, agitation, aggression, to mania, to psychosis, right? And the apathy can be characterized by withdrawal, lack of interest, demotivation. Similarly, psychosis can be any type of psychosis, agitation, same. So usually, if there one part of the cluster is there, other thing can be there. So, for example, somebody deluded, unlikely there can be suspicion, misidentification, a lot of psychotic symptoms can be there. So I'm not going into a lot of detail because it will be coming again and again to the symptomatology. But the important thing is, this is BPSD is actually associated with greater functional impairment. This is the thing. Other thing, the cognitive impairment usually correlates with the behavioral and psychological symptoms, but in non-demented patient, it may not correlate, right? But it's very clearly associated with functional impairment, and it leads to institutionalization, accelerate dementia, and causes caregiver stress. A lot of caregivers get tired, exhausted, depressed, and it's the main marker of poorer quality of life. And it has an increased risk of death because of the falls, other morbidities are increased, and more neuropathological markers of dementia are seen when they are demented. These are the CACHE study, 2019. I mean, for academic purposes, I highlighted this. High prevalence, right? Even in normally, cognitively normal old adults, there's around 15%. And cognitively impaired, no dementia, again high, and dementia is very high, right? In people with dementia, at least one clinically significant behavioral and psychological symptom is predictive of progression of disease to the severe illness or the death. This is a marker that we need to understand that dementias are end-stage diseases in life. So unless you start all the treatment from disease modifying to management of proper management of cognition, behavioral, psychological symptoms. The total package is needed to alter the course of the disease. It's a deadly disease otherwise. In cognitive normal adult, total burden was associated with longitudinal cognitive impairment. These are the same findings. You see, the CATE study findings are interesting. They have apathy, sleep problem, irritability, persecution, depression, misidentification, hallucination, wandering, elation, agitation, anxiety, and confabulation. There are a fair number of people without dementia having, but you can see very clearly when it's goes to dementia, there are very significant numbers, right? Most of the, I think the highest problem is apathy and irritability and psychotic symptoms. We manage in Sri Lankan setup also, we studied some time back. This is our own study. People who are getting to the getting into the geriatric unit NIMH. This was done 2015 and 16 and presented in the Royal College of Psychiatrists. A lot of our patients are also having remarkably high number of psychotic symptoms, delusions, then depression, as Vasanta told you, very high. Disinhibition, irritability, all the symptoms that are usually seen in the other part of the world are also seen in our countries and patients. Then associations are very interesting. You can see the memory impairment, subject impairment has a higher prevalence of symptoms. And vascular morbidity is associated with the increase of other mood symptoms, right? And co-occurrence of symptoms also noted. Hallucination and misidentification, anxiety, apathy, and depression, irritability, persecution, and wandering. That's why at the beginning they usually occur in clusters. And even in our study, we did the fact analysis and showed if the anxiety comes, they can go to more great anxiety and then depression. The clustering pattern we showed even in Sri Lanka. Now, coming to depression. Late life depression is associated with brain disease. This is the norm now. Coming from Parkinson to mild cognitive impairment, dementia, Alzheimer's, vascular dementia, Lewy stroke. So if somebody is getting for the first episode of severe depression, you have to suspect at least ischemia. It is organic. I think when we were learning, there were no major MRI studies. We used to learn this, it's called vascular dementia. Sorry, vascular depression or mass depression. They were kind of depressions that were associated with brain diseases. Now we have clear understanding what are these disorders, and so assessment have to be very specific, as Lasanta told, and it is a very extensive assessment. Leading to neuroma, which is covered by in our talks. Then ischemic. Right, white matter hyperintensity, especially prominent, right, in the frontal lobes and basal ganglia and subtle. Sorry. Right. Neurological abnormalities and reductions in pyramidal cell volume may be present in key areas of the frontal subcortical circuit. All white matter hyperintensity in depression was ischemic, as opposed to non-depressed and associated with vascular. This is I'm a psychiatrist, so when depression is treatment refractory, we nowadays almost always go for an MRI. Then clearly we easily detect this hyperintensity and ischemic area. So then you have to tackle the ischemia with a lot of difficulties. Then only they develop. So treatment resistant in old age is very clearly associated with this. And in about 50% of late life major depression, vascular disease is the important factor. This is in the Oxford textbook of psychiatry. They have highlighted a large number of studies. Then the other important thing is the apathy, and it's evident in three domains: either goal-directed behavior, goal-directed cognitive activity or emotion. They are we usually measure it's like hyperactive delirium, very quite slow and not interested, right? But only with clear mental state examination, you will be able to identify that it's distinct from depression and closely correlates with agitation and depression. So this is not easy business. Some of them are severely depressed, apathetic as well. As once you start treating depression, all the apathy will start manifesting. Then apathy diagnostic criteria, right? It has to be assessed relative to the previous functional levels and not attribute to intellectual impairment, emotional distress, or diminished consciousness. Emotional distress is absent, must be present most of the time for at least 4 weeks. Minimum of one symptom should be evident from 2 of the behavioral, cognitive, and emotional domain. And the apathy should cause clinically significant functional impairment. They will say that they don't have the energy. Even the carers will say that even the feed, they don't have take any initiation. And differential diagnosis is important because some of the medications that we use can cause apathy, right? Like antipsychotics, antidepressants, neuroleptic, other neuroleptics can fatigue, lethargy, restlessness, and reduce response to patient. And the other interesting the chances don't miss depression, hyperactive delirium, and daytime feverity, insomnia. And a lot of other beta blockers, many cardiac drugs can cause like symptoms, right? Androgen blockers. So you have to, assessment is apathy is quite difficult in old age. Management is quite difficult again. Evidence is limited. So it's, they talk about multisensory stimulation, VR, game-based intervention, OT activities, stimulation, creative activities, cooking, Montessori method, physical exercise. What we have seen, assisted physical exercise and engagement and stimulating activities, they do help. Then pharmacotherapy, again, is difficult because associated side effects, right? When it's very severe, one can try methamphetamine, which is usually used in children, the Ritalin, and the improvement is not great. But if they are traumatic brain injury, post-stroke, the response is better. And antidepressants again give very mixed results. Then coming to manic symptoms. It may occur in the context of bipolar affective disorder, or from young age to the late onset, early onset depression connected to bipolar type because of the treatment, second, right? And late onset is most commonly secondary. If somebody is getting a manic symptom in a very late life, after 65 or 75, the chances of it's more secondary causes. And associated with increased cognitive impairment. Prevalence is commonly 0.6% in above 65%. So it's a rare compared, but depression is the most common, apathy and the most common one. And late onset manic symptoms, elderly may have less classic manic symptoms. And there are mixed episodes, very difficult to identify. Most evidence for vascular. And so if again, the assessment, quick comprehensive geriatric assessment and MRI is important because increased white matter high intensity dysacia, more vascular involved in the deep frontal and parietal lobes and putamen. And DD again, right? It can be pure dementia syndrome, vascular mania, traumatic brain injury, slow growing tumors. And interestingly, even in our setup, we have detected slow growing tumors, temporal lobe epilepsy like, and HIV, metabolic disturbances, endocrine disorders. So it's assessment is quite has to be very comprehensive. And steroid. Now, after the recent COVID pandemic, we start seeing steroid induced manic because most of them are survivors, long COVID survivors were on steroid high, and they were going very high. It was kind of difficult to keep at home. First episodes. And management, again, thorough evaluation, low dose antipsychotic, very important because they have elderly are very sensitive to neuroleptics. They can fall, get oversedated, and a lot of even go delirium if you unnecessarily high doses. And again, mood stabilizers have to be very cautiously given. All the mood stabilizers, lithium, valproate, lamotrigine can be highly toxic in elderly. So it's starting low dosing, gradually titrating is important. Anxiety symptoms. Anxiety is a much more common than anxiety disorders, and it's regulated by the limbic system. It's associated with increased rate of conversion from mild neurocognitive disorder to major neurocognitive. And when there's anxiety disorder, there's almost always comorbidity, either diabetic, hypertension, dyslipidemia, ischemic heart disease, arthritis. All these comorbidities are highly associated with anxiety disorders in elderly. Again, differential diagnosis is very important. A lot of Alzheimer's can start with anxiety symptoms in preclinical stages, and it's associated with cerebral amyloid lot. And medical illnesses, again, as I told you, then Parkinson is the highest rate, I guess, and the medication induced. So it's iatrogenic, some of the anxieties are. The management, first thing is to address the medical cause, then substances, medication. Anxiety is actually improved by physical exercise and activities and relaxation activities. So elderly can be also taught easily relaxation activities and restore sleep, sleep hygiene, good therapeutic relaxation, education, and very specific relaxations can be in, and behavioral CBT if they are educated and have the organized lifestyles. Then medication is the last option. Obvious reason. The agitation is again a behavioral symptom which is associated with increased motor activity, restlessness, aggressiveness, and emotional distress. And they all have a frontal lobe dysfunction, anterior cingulate cortex or orbitofrontal cortex usually, and often accompanies psychosis. So agitation, psychosis is coexistent like a large number. And dementia, 30% increase of with the risk. Treatment of agitation, again, behavioral measures should be tried first, but easier said than done. So somebody has to well train occupational therapists, nurses, on. Then antipsychotics recommended are risperidone, aripiprazole, and clotrimazole if it's essential to use it. And some meditations associated with anxiety, depression, also improve with selective rehabilitative low doses. Again, you have to be very careful. SSRIs are nasty in causing low electrolyte imbalances. So all these antipsychotics and SSRI, we have to start slow, monitor, and carefully titrate. Coming to the green monster of elderly care, the psychosis. Psychosis is the most difficult part to handle because of their vulnerabilities and sensitivity to antipsychotics. And it can be due to possibility of primary psychosis, early onset schizophrenia, very late onset schizophrenia, affective psychosis, delusional disorders, or secondary psychosis. And it's important to remember that 60% of psychosis in elderly are secondary. Delirium, neurocognitive disorders, neurological disorders, medications, substances, especially in Parkinson's and other movement disorders, it's due to medications. And DDs, you should consider Alzheimer's, vascular dementias, and the highest possibilities everybody knows by experience can be the dementia of label type or delirium. And Parkinson's disease, right, itself can have a complex hallucination and Huntington's. That ends my discussion. Thanks for your attention. We'll be answering questions the trainees are having in the Q&A session. Thank you.